My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Poppy,
and you're listening to the Fix Podcast.
your source for all things implant dentistry. I'll tell you that whenever anybody mentions like, hey, what's the course that you'd recommend going to for implants? I mean, we recommend it, but everybody recommends it. It's like, hey, Pathway,
Yeah.
you can get to Fast
First and
Track.
foremost.
Like that is the place to go if you want to like start placing implants. So you guys have done such an excellent job with not only marketing yourself in that space, but also creating that environment where when people go, they have a good time. Doesn't matter what their background was, they feel like they, learn a lot from it, and they don't feel like judged by. I feel like you go to a lot of full arch courses, and the first thing they ask is, "How many arches do you do currently?" Or like, "How many implants do you place?" And it turns into this kind of like hierarchy type of thing. But in the reality is like, people are coming to Pathway because they probably don't have a ton of surgical experience, or if they do have a good amount of surgical experience, they're just looking for a good, solid, basic education on placing implants because they want to provide that to their patients. They want to provide a solution that the patient doesn't need to get that bridge and, prep two virgin teeth that probably will last for a really long time or whatever it is. But I feel like so many dentists, especially in rural environments, they just don't have anything like that near them. So it's really cool that you were able to create that. And Tyler went and he got all aboard implants, and I know I kind of trailed on Tyler's tails and got into the implants as well. So I mean, I'll say that probably is what got us initially into this space as well. So we really appreciate that. And we have had I talked to Chris a lot. And I love Chris, and I think he's a great clinician. And he told me all about how he was in Denver here, working under the doctor here, and then made his way to your office and really got to dive in. Because I think when he was here, he was doing a lot of restorations, a lot of like occlusal, like making sure everything.
Pros.
Yeah, a lot of pro stuff, and then he wanted to get into the surgical part, so he found you, went there, and I think that that was a great opportunity for him. And now he's, we talk about him on our podcast. He's like one of the guys I look up to for a lot of the remote anchorage stuff. Like him, Holtzclaw, a lot of those guys. When you're trying to fix someone who comes into your office who has maybe been through the ringer already and they've got zero bone left, like those are the guys that I look towards for figuring out the solution to that case.
The last stop.
So you're right. The people around you are what you're the best for the people around you. And Chris is great. And, we had a opportunity to work with Vorholt for a couple months too. He's been great to us and a very good clinician as well. So I think that, you did a great job with establishing people in our industry that were looking for that next step in implant dentistry. And now we have such a great opportunity to learn implant dentistry at Pathway. So we really appreciate that.
Well, I appreciate that, but those things, those things mean the world to me because, I couldn't be any more proud of, like a Chris Barrett. I remember him placing his very first implant in Pathway because, he came out of, a high-end cosmetic practice in Cherry Creek. He left a practice that hundreds of dentists would like just be foaming at the mouth to like be in that kind of high-end practice. And it wasn't fulfilling to him, and to see him not just take advantage, seeing Chris place his first implant to, having a conversation about like, he's like, man, I think I'm gonna go learn how to do like the zygos and teres. And I'm just like, oh, like go do it. Tell me how it is. Cause like, I'm not 100% sure I'm not interested in it. But he came back and like, it was like through another log on fire, right? Like it was getting him up and like going in the day and he's the most even keeled human on the planet. Like he's unrattled. Like you can't rattle him. And, I love those stories, and I think about the people that just blossomed, in that, on the mentor side, from Josh McGow, and of course, Wade, Wade was, good when he came in, and, all the people. And then there's, I don't know if you guys know who Tommy Graff is.
Yeah.
Yeah.
Yeah. Yeah. So, one of the docs that take the course this week was referred, came because, Tommy told him he should come. And I always tell people, like, I ruined Tommy harder and faster than anyone else on the planet, because like he took Pathway, and then like 3 months later, he took Chris and Raj's All on X course. And then like 3 months after that, he called me one day and he was just like, "Hey man, like, I get this crazy idea to run by you." And I was like, "Yeah, what's that?" And he goes, "Yeah, I think I'm going to fire my hygienist and everyone in the office and turn my office into an implant only center."
I remember when he did this.
And I was like,
Tainted him.
shit. But then I was like, you know what? I did the same thing.
Yeah.
Like I left, it wasn't for an ARC center, but it was for all implants.
Uh-huh.
And I was just like, I left that private practice out because I didn't want to do it. But I wanted to be happy, and I wanted to do things that fulfilled me. And look at him now. He's got Chase with him, and and all the things, and you can see it in his voice and the way he promotes his practice and stuff. And I can't mention them all because they're like the list is long, but like it's what's really it's what makes me get up every day and love to go down to the center. And now we've got this big beautiful facility and like all this other stuff. And but it has not, it's funny because people are like, "Oh my God, you got this like beautiful facility and all 32 operatories and all these things." But I'll tell them, like, it's only as good as the humans that walk in that door.
Yeah.
Mm-hmm.
That building doesn't do anything. The building and the equipment and stuff, they don't do anything for teaching and getting people to do things. Like it's all about the people that come there.
I think something that impresses me the most about Pathway is, as it's grown, it's remained and almost become more nimble over time in terms of, as new techniques become more, proliferated into the general consciousness, like remote anchorage and things and new technologies. Pathway has a course on it almost right away. And you guys are able to offer so many different courses for whatever experience level people are coming in with, what they're trying to get to. And I think a lot of that speaks to the mentors that you guys have in your atmosphere is, as they continue to push boundaries, you guys are democratizing that into courses and bringing people into it in a, obviously in a safe and controlled environment. And, a lot of times as organizations grow, it's even harder for them to innovate. It's harder for them to increase their offerings and create that for people. And you guys have managed to do that just wonderfully.
I appreciate that because I find those courses, like I told you, I even I gave up the teaching, being the lead instructor for the sinus course. Andrew Curry out of Atlanta is teaching it for me now, and I do that because like the mentors that come and give of themselves, they're doing this on a day-to-day basis, and I think about some of the recent courses that we've added to it. Obviously, Dan Holtzclaw and his remote anchorage. Like, today he only does 4 docs at a time for the live surgery thing. Like that's it. It's small lot. And yesterday he did a demo quad zygo with an incisal canal, and then today I think Doc Leland did a quad zygo with some transnasals and like crazy. But there's a call for that, and I think that being nimble to create that next step is like it's okay to go out of country and do those cases, and we know why people go out of country, but like for me, like I think you can serve more people being here, and we can serve the dentist better because those procedures, like they got to be taught to treatment plan and provide the care, the follow up and stuff, and to the standards at which we would be held, and it's got to be as close to your simulation of your own practice as, as possible. And you're just not going to get that in I think outside of the US. But I also think that is one of there's two courses that I think are the most important new additions to the course. The one is the remote anchorage, because as Clear Choice and everyone out there has been eating up arches and and mowing down bone and creating FP3s and stuff. As we've done this, there's a tsunami of complications coming.
Oh yeah.
There's a tsunami of failed arches, and this has nothing to do with bad dentistry. This has everything to do with time. And I'll tell you, arches that were done 10 years ago are on implants that are nowhere near the technology that we have today,
Right.
on techniques that had yet been refined.
Yeah.
Yet we did them at a high level, and the issues that I have with that is that the damn courts and people judge us today by what we did 10 years ago. And it's not right, because the technology and the techniques and the reps have increased over this amount of time.
Mm-hmm.
And you can't not solve for that. Right. So there's a need for remote anchorage, because as implant dentistry and full arches, age and fail, some of these people, that's the only place they're going to go. That's the only solution they have at that point, is to, be able to go to those. So that is one of the reasons. The other one that I'm really passionate about is the FP1 course that Josh and Wade are doing, because, what you talk about, just what we did, is we need to really learn about these, how to deal with younger people that have bone. And, if you're getting this done in your 20s, 30s, and 40s, you're going to need a revision in your 50s or 60s.
Mm-hmm.
And without a doubt, not everybody, but there's a good piece that are going to be there. And then what happens when the revision needs to go? Well, then the next step is
Remote anchorage.
The next step is remote anchorage. And this lies in line, but the FP1 is a stepping stone and a bone. I call it a bone holder for those humans that don't need to have an arch mowed down. And I feel I'm super passionate about that being treated the way it is.
I got a couple comments on what you said, and one of them, the first one, is talking about the courts and how they're seeing cases that maybe were done 20 years ago when we didn't have the technology that we do now. And I get frustrated about this too, because my thought, kind of what I compare it to, is that 30 years ago, almost every, and correct me if I'm wrong, but a lot of patients that were going through ortho got all their their premolars out, and took out all the premolars, the first pre's, and then did ortho. And now we don't need that anymore. But if they went back and ostracized every single orthodontist that did that, then, because that's the technology they had at the time, there'd be so many orthodontists that be sitting in court because they were taking out virgin teeth that maybe didn't need to be taken out. And I would say the same thing. At the time, we didn't have photogrammetry. We didn't have all of the solutions that we do now, but the dentists were just doing the best that they could with what they had, and trying to please the patient to give them a remote anchorage solution. And maybe they didn't know about root banking and, socket shielding and FP1s and all this stuff that have come out in the last 5 years. And sure, it probably would have been a better treatment option to give a 28-year-old a nice FP1 with all these solutions. But at the time, that technology wasn't out. And the only thing that they had was an FP3 prosthetic, and it was either that or a denture. And you know damn well that if they put them in a denture, there's either that or a denture, and that they do now getting the,
Yeah,
and I hope
that's right.
that as some of these, if more and more of these cases kind of come to court, that becomes, that people kind of mention that, because my opinion is putting somebody in a denture too, like they're going to eat away bone over time. No different than
Yeah.
putting in implants.
Let it happen naturally or artificially. It's
Right,
still happening
exactly.
the same.
And
Yeah.
you can't ostracize somebody for doing the best they could with the technology that they had at the time that those implants were placed.
Yeah.
So that's
Yeah.
my opinion on that.
Well, your opinion is not wrong. And the, we live in a world where you can sue anyone for anything, which is like whatever, but, we need to, and I was me and my generation were guilty of when for implants, like literally 27 years ago when I started doing this, like nobody really believed in them. You didn't have long track records, didn't have long studies on them, things like that. They were just starting to get kind of mainstream, but no school was teaching it when I was going through there, and um, we contributed because we sold implants as like, hey, like there's no nerve, there's no need for root canals, you're not going to rot, the teeth aren't going to rot, but we didn't. I mean, I remember, when I left Mish, like I was placing the BioHorizons square threaded parallel walled external hexed implant, which no one places today. But that was, according to the literature and what we had, like that was the best implant that we had.
Yeah.
And yeah, it loses bone down to the first thread. Most of the time it does stop, but like we sold this as being we sold it as being a super treatment when it was just a treatment. And, it's better than the average, it's better than a bridge or a denture, but it's not forever. And we cycled through that, and now we're seeing it on the backside. And these people, they're paying 40, 50,000 for a dual arch, and they have some implant loss, or they have a prosthetic loss, and they're like mad, and they think that this should have, survived forever. And the reality is that, for one, I think dentists don't take enough that I don't think that we honor how a patient loses their teeth enough. And what I mean by that is like when they come to you needing a full arch, they're already speaking to you in an unwritten language that they don't have a track record of taking care of their teeth. Whether it is their love for crystal meth, or perio, which are two separate problems in themselves. Like one leaves you with bone and one leaves you with no bone.
Yeah.
But the reality of that is that it's different dentistry than single tooth dentistry, because you can take great care of your teeth and break a tooth and have to have an implant. And those of us that are in the arch world, not all of these patients are going to be like, just because they can afford to fix them doesn't mean they're going to take care of them. Doesn't mean they're going to do any of the things that we ask them to do. And when we take that into consideration, we've got to understand that a certain population of those dentists, of those patients, we're going to have some bone loss. We're going to have periimplantitis, and ultimately we're going to have revisions and things, because they're just not going to do. And we also don't take into account enough, I think, that the patients sometimes are not good hosts.
Mm-hmm.
The older they get, the worse we heal. Like there's lots of things there along the way. So
health issues, diabetics, maybe
all different
for
reasons. Sure. I tell this story, and I don't mind. We talk about health histories, and like you mentioned diabetes. Well, it's fine, but so many people in America don't even know they're diabetic, and when they don't check the box, you can be what I think to look fairly healthy and be a raging diabetic and fool everybody, because as dentists, we really I mean, I love the health history with all no answers. I mean, it's, I don't have to think about it, right? But now I think more about that because I was like, okay, I'm going to correlate, like, okay, this person's in their 50s. They put all no answers down. I'm guaranteeing, or I'm thinking about the patient. Maybe they've never even been to the physician. So their no answers are truthful to them, but not necessarily the reality. And I'm going to give you a case in point in that in January of 23, when I went to the Mayo for my executive health that I go to every year, my hemoglobin A1C was 9.7. But you know what? I got up and went to work every day, and I didn't think I felt bad. Then today, for coming up on 2 years, I've got a continuous glucose monitor on my arm. And in January of 24, I had it down to 7.6. And then in July of 24, I was at 6.7. And then Monday was my 3-month check, and I'm at 6.6.
That's great.
Yeah.
And, so, and I say this because I didn't have any of the other symptoms. Like I didn't get up in the middle of the night, pee, I brushed my teeth every day so they weren't bleeding, like all these things. Right. But like, I was headed the wrong direction, so like, I, lost 37 pounds and I did all this stuff. And my point of that is it's like so many of our patients don't know.
Yeah.
Because they don't go. And it's so important to implant dentistry is to understand that, because as we get into the arches, we're dealing with older people.
Mm-hmm.
Like we get some of those young ones we were talking about, FP1s and things, but the vast majority of the patients that we see, I don't know, what do you guys think? They're over 50 probably, right?
Oh yeah. Yep. I would say
usually, yeah.
Yeah, I would say, we do arches in patients less than 50, but a majority of my patients, I would say, are 50 plus for sure. And I agree, it just is part of our population, the population that's coming in that need all their teeth removed. Typically, the reason that they need all their teeth removed is because they haven't gone to the dentist probably as much. I mean, there's a lot of reasons, right? But one of the reasons is maybe they haven't gone to the dentist as much as they should have. So I think you're spot on in the fact that, it's probably good to, if they're not going to the dentist as much as they should have, maybe they also aren't going to their physician as much as they should have. So when that patient comes back and they have a couple failed implants, it's probably, good to get a blood panel, make sure they go in and see their PCP and ensure that they're healthy. And those are the reasons why you can probably figure out the reason those implants failed. But it is, and I think that it's difficult, right? As a provider too, because you have a patient that's coming in looking for a solution, and they, maybe they've got a ton of infections going on, and you want to provide that solution to them. And the best one you can offer is something fixed. But if they go through their whole physician care, that it might be 6 months down the line before they can get that done. So it's tough, right? Like, it's like, okay, do we fix the teeth first, or do we fix?
That's actually, it brings up something interesting. I was at the ICOI. Well, we were both at the ICOI recently, and a doc that was a fan of the show had come up to me, and he talked about how on one of his patients they had some undiagnosed condition, and he'd done a full arch on them, and all of them had failed. And now he's like, well, now I do a blood panel on all my patients, and I'm like, that's great. And he was like, are you not doing that? And I'm like, well, no, I'm not. Even though in theory that sounds like a great idea, and I'm sure that over time I would reduce failures and things like that. Got a lot of patients that, if I tell them that they got to go get a blood panel and we got to see different specialists and we got to make sure all this is going, they're never coming back to me, and it's not just about keeping the business going. It's about like, this patient needs some sort of intervention. And most of the time, that blood panel could come in handy, but most of the time these things do go well. So it's this question of like, do I want to take every single precaution possible to catch all of those things? Or is that going to now become a barrier to treatment for people? I really don't have a great answer for that, but it brings up an interesting question.
I actually think the answer lies somewhere in between.
Mm-hmm.
And here's why I think that is. I think what we could do. I agree with you. Like, if every patient that walked in the door that needed a full arch, then you said, hey, listen, like, you got to get over to your PCP and like. Get a physical exam and a blood panel and stuff. Like, we'll do far less of them. would it make healthier candidates to have the data and stuff? Yes, for sure.
Yeah.
But I think that there's things that we can do. I think there's things we can do, and I think it's because I think it's how we become a better detective. And I think it's like going through the health history and being more Jacques Cousteau, right? Like asking more
Be a detective.
questions about
Yeah.
as we get through there, and it's just like, hey, like, tell me about when last time you went to a physician. Oh, we haven't been. Like, okay, like, well, tell me about how you feel. Like, have you ever had your blood pressure checked? Because we just took it and it's a little bit high. Like we're just trying to, I want to know if that's average or you're just, nervous because you're here. And someone asked me like, well, how do you know if they're titanium out? They're sensitive to titanium. And I was like, oh, you can do the Melissa assay test, and that. It's the same thing. If I sent every single person for an implant for a Melissa test, A, it's expensive, and B, I'm going to lose most of those implants because they're not going to go. But what about deep diving? Like, hey, Ms. Jones, like, I see that you had your knee and your hip replaced. Yeah. Well, like, how'd you heal? Right? Like,
Yeah,
how'd that
Yeah.
go? Oh man, like I had no problems. I was up on it and I said, well, how old are they? Well, they're 5 or 6 years old. You had any issues? No, like I haven't. Well, listen, you just got a small snapshot of the patient's
Yeah.
not titanium sensitive.
No way.
But what if the patient says, I've had my hip redone a couple times and my, I'm probably going to have it done to my knee. Cause like, listen, that might be your clue, right? Like that's your breadcrumb to, wait a minute. Like they're not taking to this prosthesis well. They've had multiple problems, which is not uncommon. And if they have, like, who's to say it's not the metal? And all I'm saying is like, maybe that's worth the deep dive and maybe that's worth the assay test to do it. So when we talk about, a full chem panel, like maybe we do that on the human that is 50 plus, that's never been to the physician and has, numerous lesions and things like that. Like maybe, and maybe that patient's, think about this. Maybe that patient, I always tell people, man, I like to watch my patients a little bit of the waiting room, and I like to watch them walk to their operatory because it tells you a little bit about them, right? Like, can they hop right up and can they walk down the hallway, or are they winded when they get there, right?
Yeah.
Did it flush? Did it flush them, right? Like, look at their arms. Like, do their arms have bruises on them? And like there's little things that we forget are clues to a patient's overall health that may lead us to that. You know what? I think this one, like before we spend $50,000, and I've done this, and I preference it with, doc, or patient, Mr. Jones. Have you bought a $50,000 car before? Well, today, I mean, that's actually kind of an average price car.
Yeah.
So like,
That's a Honda Accord nowadays. We were talking about.
Right? So like,
Yeah.
so if you bought tell me, like, if you bought a $50,000 car, like, you're going to kick the tires and take it for a test drive and look around and that, Mr. Jones, I think we need to do the same thing with here because, before you spend 50 grand, like we need to put it up. We need to put it up on the hoist and take a look at the drivetrain and take a look at the tires and make sure that what you're paying for will get you down the road a ways. And I always like car analogies. The reason I like car analogies is everyone has one.
Mm-hmm.
And the assumption of owning a car is that, you're going to need to change the oil and change the tires periodically. Like, they're not maintenance free. The Tesla makes it a little less maintenance, but they're generally maintenance free. They're not maintenance free. So the analogy works. Like, hey, like, would you? It's the same thing I do with when people, balk at. One of the things I do with my full arch patients is, hey, listen, if you're not committed to spending $1,000 a year with me for the rest of your life, I'm not committed to doing your work. They're like, what do you mean? I was like, well, like, you gotta, it's like your car. Like, would you buy a $50,000 car and then be like, you know what, I'm not putting another dime in this damn thing. I'm gonna run it till the wheels fall off and the oil's empty and the radiator's empty. And the answer is no. But yet you not coming in for your maintenance is no different than there's zero difference between that and running your car out of oil. And they get it because that analogy works for almost every human on the planet. So I don't know if that made any sense or not.
No, it absolutely did, and I actually love that analogy. I'm definitely going to use it because you're right. When a patient comes in and they look a little bit, you can tell, like they look a little like they probably should see their doctor. And I think a great way to let them know that without them just going across the street to the next provider that'll just do it for them, is just let them know, like, hey, listen, you're spending a lot of money. This is a big investment for you. If you're going to spend this amount of money, we want to make sure it works. And I don't want you to have to do this twice. So in order to do that, like, let's at least get a checkup for you. And a good way to put it to them to make them understand is probably something like that. Like, what's another big investment you made? How did you prep yourself for that investment before doing it to make sure it was a good investment? And let's do the same thing for you here. And I think that by telling them that you're not doing it because you're trying to be a stickler or anything like that, you just do it because you care, because you don't want them to lose more money in the future. That'll go a really long way for those patients because they probably don't have enough money to get it twice. So let's make sure that they don't have to, right? Or let's make sure they don't go through 8 months of implants before doing all that stuff and then having to do it again, because that's a year of their life, right?
Wow. Yeah. Those things are I think those things are so accurate because, um, I always use a line, I use a line to all my patients that I truly do believe in. And that is, when I'm talking to the patients about, whatever it is, whether I really need them to do a chem dental or, I want them to consider this treatment. I will tell them, I said, listen, I would never do anything to you that I wouldn't want done to myself. Like my commitment to you is like, I will never provide a treatment for you that I would not have done to myself in that situation. And in this situation, knowing what I know, I need more information. And that's for you to get a quality product that can have some kind of resemblance of function and longevity. And listen, their answer also speaks volumes to whether you should even be working on them to begin with. Like if they don't see that and honor that, like that's probably not someone that you should work on to begin with.
Yeah, agreed, 100%. So this was something that I wanted to bring up earlier when you were talking about providers that have come through Pathway that you've seen excel greatly. You talked about Graf and Barrett and Pilling and some of these guys. I'm just curious what are your thoughts on what make a good implant surgeon? Like what makes a good a surgeon in your eyes? Because I have a lot of colleagues that I'm friends with that do general dentistry, and they maybe want to get into surgery, but they're not super comfortable with it. And sometimes I tell them like, hey, listen, or at the other end of the spectrum is they really wanted to get into full arch and they feel comfortable with it, but they also have a lot of anxiety about little procedures. And at least my opinion is, I think it's important to, um, especially when you're getting to full arch, to kind of be able to manage some of those problems, because there are going to be issues that come up when you're in surgery. And I'm just curious, like, what your thoughts are on like what makes a good provider that can do these big surgical procedures well.
There are, we've trained a lot of doctors through here, and I've seen docs come through here that are in that kind of like, I want to do more surgery, but I don't really know how. And they take out a bunch of teeth here, and sometimes a light bulb flicks, and there's like, shit, I just needed to be taught how to luxate teeth and how to take things out without breaking buckle plates, and suturing sometimes is the barrier of entry to people because they just like you don't get it in dental school, right?
Yeah.
And then you also see, and then some of them contribute, some of them, they thrive in it, and then some will be like, we've had people, we have a high 90% success rate that goes and places implants, when they get home. But like, there are docs there's docs that didn't love it,
Mhm.
and they go back home. But you know what they did, what they will tell you, and some of them are still great friends of mine. I mean, and they'll tell you, like, what I learned was I learned how to be a better referring doc to my specialists.
Mhm.
Like,
Mhm.
I learned that instead of writing off my script to my surgeon or my periodontist, put an implant at cheek number 30, I learned from you that, like, hey, listen, like I'd like you to use a biohorizon implant, and I'd like to have it sized where we have at least 1.5 millimeters of buccal plate on the crest of the bone, and I need the implant to be centered mesial distally and parallel to the contact points, because the final restoration is a screw retained crown. And I was like, that kind of took me back for a minute, and I was just like, yeah, right. Like you'll get better product back by being educated and be able to ask for what you want, instead of just being like, hey, you just replace 30 with an implant. Well, so it's off. Every go to the surgeon, just get, well, just put a custom abutment on it. You can make a smaller check around, like it takes them off the hook. But what I think is the profile of it is, I think someone that's looking to be challenged more in their career. And I think surgery is that a little mystical, for the dental student, like every school is different. Like some get it, a lot of it in like schools that don't have surgery residencies get the docs get to do more of them in undergrad.
Yeah, absolutely.
In dental school. Schools that have an oral surgery program in the building don't get to do very many.
Yep.
They get and they get the same with endo and perio and all the all the other things. So I think surgery becomes a little mystical, and the only way to get better at it is through reps. And I think that the profile of the implantologist is that of, I need to be challenged mentally and physically to treat the patients, and fillings and crowns aren't doing that for me. Does that make sense to you guys? Like,
Yeah.
I think it does.
it's interesting you bring that up, because I thought about that profile, and that's the best way I could describe it.
Yeah, I think
Well, I think it's kind of goes back to when you were talking about Barrett earlier, when he first told you he wanted to go and do Terry's and Zygos, and then all of a sudden he was just jazzed. Like that just gave him energy, and he just went after it. And it's always that kind of next challenge. And I think Soren and I have talked about this before, because a lot of our training has been just like, we've kind of been in the same cadence and advancing ourselves. And gone to all the same courses, is, we're always saying, okay, well, once I'm competent with doing this, I think that's probably where I'm going to kind of like stop. Like that's going to be like that. This is what I do.
Yeah.
This is my box. This is what I do in full arch. Like I'm not going to go do all that crazy stuff. But then as we get comfortable and as these things become more pedestrian, we kind of start asking ourselves, well, what if we just did like 1 or 2 cases, or what if we just went to this course? And then before we know it, like that's giving us energy, and we're chasing after that. And I think what you just identified is spot on.
Yeah. It's the progression of the human, right? And like, are you, is dentistry your passion? What I do know, I don't know anyone that gets into implant dentistry that dentistry is not their passion. I know plenty of dentists that just do crowns and fillings and hygiene checks, and dentistry is not their passion.
Mhm.
And I there's a good delineator there.
Yeah.
Yeah,
I think,
sure.
one of my and this is kind of on topic, but one of my core memories of kind of getting into surgery, because I definitely have the mindset of like I need to be challenged. If I'm not challenged, I get super bored and I just like look for the next thing, right? Um, and I always wanted to get into surgery, and I was doing a good job in school. I was getting a lot of reps and stuff like that. But one of my core memories that was kind of a gold nugget for me that hopefully, some people listening that maybe are dental students or whatever it is might take a lot out of was I remember I was working under an oral surgeon as a mentor for a year, and I was really blessed to have this opportunity. But he always was like, I always kind of looked at him as like a little bit of a crutch, where I'm like, man, I've been at this molar for 20 minutes, and I just can't get it out. And like, I sectioned it, and I got there, and I got to the root, and I feel like the patient's starting to get uncomfortable. Maybe his numbness is wearing off a little bit, and I just like, started to get that feeling in the pit of my stomach. And I went to him and I'm like, "Hey, doc, like, I just, I'm having a really tough time with this root. I can't get it out. It's stuck down there." And I remember him just looking at me. This is Dr. G, and I talk about him a decent amount because I learned so much from this guy. But he looked at me and he's like, "Hey man, you're gonna be on your own in 6 months. Like, am I gonna be here for you in 6 months when you come out? Like go back in there and figure it out." And I think that that's like a really important mindset to have when you're learning these initially, is just go through all of the steps that you can. Because when you're at a course like Pathway, right? Or you're at one of these courses, it's the easiest option is always to go and like ask for help and get someone to help you. But the fact of the matter is, what's going to make you a better clinician long term is figuring out, that solution to do it by yourself. So I urge people, like, when they are at courses, that they have someone behind them that needs help, without, doing anything destructive to the patient, but really take all the steps that you can to try to figure it out yourself before going and asking for help, because that's what's going to make you a better clinician long term. And being able to kind of like jump over those hurdles is what's going to allow you to get into these more advanced dentistry over time and allow you to do it faster.
I think what you're describing is what I like to call critical thinking,
Yeah.
And critical action, right? Like, and I think, I think I've defined critical thinking in implant dentistry as this: like, you have, science based, right? Like science says we should do this. Literature shows we should do this. This is the technique that we should do this. But then the other half of it is fucking common sense.
Mm-hmm.
Like, should we do this? Is the patient healthy enough for this? Or do I have the skill set to do this? Like, I think critical thinking and critical action comes from blending the known scientific portion with the common sense, like reality you have, and you come together and you exercise something that I think is being lost in society, right? And that is problem solving.
Yeah.
Like what you're talking about is going into a surgery and solving for a problem that is there. I think our society is making it too easy to just quit, right? I need a mental health day. Like, I can't take it, like I'm just like, are you kidding me? Like, I could only imagine if I was like on the ranch and I told my dad one day, I was like, you know what? I'm not fixing fence today. Like, I need a goddamn mental health. I can't do it. So like, I just can't even imagine saying it. But you know what? I bet that the clinic here, there once a week, someone calls out because they're looking for a mental health day, and I'm just like, I like, help me with this, because I'm struggling with it, and it's about like looking at a problem using logic and common sense and critical thinking and problem solving abilities to just solve for it. And sometimes, like, okay, I sectioned this and it's still not rolling out. Like, why is it not rolling out? Well, it's still hung up.
Yeah.
Okay. Like where is it hung up at? On a molar, on the mandibular molar. Like, well, where am I going to remove more bone now? Well, we're not going to remove it on the lingual side. That's dumb. Well, let's let's take it out away from structures and away from nerves and things that like decrease the risk. That's critical thinking, problem solving. And to your point, as a young dentist, like, the best medicine is to just stand in there and do it, because you're gonna learn what works. And after a while, you're gonna be like, you'll learn after a while. Like you see that scenario on a panel or a CVCT, and you're just like, you know what? Every time I've taken a molar out that looks like that, it's taken me an hour. It's taken me an hour to earn $275. And for that tooth right there, that some bitch is going to the surgeon because I can't make any money on that.
Yep. Yeah. Learning.
I mean, that's how I look at molars today. Like, if someone's in the clinic and they need their thirds out, I just look at it and it's like, it's not that I can't do it, but it's like,
time.
Is it worth my time? And is it worth my post-operative potential complications and time to do that?
The liability.
And if it's not, then
Punt.
here's your referral card.
Yep.
Yeah.
Learn to overcome obstacles, and that'll also help you become, like you were mentioning earlier, a better referring doctor, right?
Yeah.
Like I remember in Rapid City, like people are just like, oh, I bet the oral surgeons, hate you for doing implants. So it's like, well, I actually, when I left there, I actually don't think that they did, because I did a good job with them. Did I have implants that had issues? For sure. Right? Like all the things we already talked about. But I think what they came to dislike more about me was when they got a referral from me, they were going to have to work.
Yeah.
Like
they're like, oh shit.
Like if you think about, like,
Justin sent me a tooth.
If Moody sends you a tooth, I'm going to tell you it's one of three things. It's going to take forever to get out because it sucks.
Mm-hmm.
The patient's either batshit crazy and he doesn't want to see them, or they're sick as hell.
Yeah.
It's one of those. It's one of those three things. So and for that, like you think about yourself, would you want a referral for any one of those three things?
Yeah. No.
But on my podcast during COVID, I had he was the then ADA president, David Clements, down in Tucson, oral surgeon. He was ADA president, and he was on the podcast, and I was kind of nervous because I was like, should I get a surgeon on, like ADA president, or like I'm teaching GPs how to do implants? And he said one of the coolest things ever. He said, Justin, specialists should do special things. And special things are not abundant bone, missing number 19s. And all the other things that I just talked about are special things. People with bisphosphonates, people with health issues, health histories, difficult anatomy, difficult teeth, all those things like that. And that's what they're there for.
Mhm.
And that's how I use them. And I think to your point, like, how do we get people to understand, like, how to be better referring doctors, and ultimately keep, identify the easier cases and the ones that we can treat because your patients we know don't want to go anywhere else. How do we keep those, and how do we, do risk mitigation and send the risky ones out the door? Because you guys know that, like, if you do that really well in your practice, you won't have that many issues.
100%. No, I agree totally, and I think that's a really good point to end on here. We're kind of getting to our end point here, and I think we had a lot of really good topics, and a lot of dentists are going to love this episode here. We went from clinical stuff to ethical stuff to treating patients properly. We have Tyler always asks a couple questions at the end here, but I just wanted to give you the floor. Is there anything at all that you wanted to mention at all to our listeners? Maybe you mentioned a couple new pathway courses, anything else before Tyler asks these two questions, and then we kind of wrap it up?
Listen, pathway, and this will sound funny coming from someone that's trying to sell education, but like, pathway should never be everyone's only source of education, because you got like, I've taken them all, from Kois to Picos to John Russo to Carl Misch to and it blends in and becomes a part of the way you practice. You know, if you if you if you're looking for quality courses that are going to get you some reps, and by good humans, because like criteria to be a mentor at Pathway is like, first and foremost, would I let them do an implant on me? Yeah, within that group, I might be a little bit selective, but like, criteria, like, would I let them be, sometime I'll tell a good story about how Josh McGowan ended up doing an implant on Wade Going. It was funny as shit, but, well, I'll tell you, Wade needed an implant, and, and it was, and so he had it down at a fast track, and like, all of us, mentors sitting around, and I'm like, oh, I gotta be the logical one to do this, right? And it was funny because Wade's like, he goes, Mood, like, it had nothing to do with your skill set. He goes, but because Wade needed a little sedation from McGowan, and he's just like, I just knew that when I woke up, I'd have a BioHorizon implant in there, and he was really looking. He wanted this Straumann BLX in there, because at the time he wanted a conical implant. At the time, Bio didn't have the conical implant, so that's what he wanted. And he goes, I knew if you did it, I'd end up with a bio implant. And I said, well, what if it? He goes, I know. And I said, well, what with McGowan? And he looked at me and he goes, I needed someone that was a little bit scared. He goes, you wouldn't have been scared. And he goes, I need a little bit scared, but I need a little bit of that Asian precision. And I was like, oh my God. Like, it was so funny. Like, it was
good.
My criteria, real quick, I was like, would I let them work on me? And the second criteria is, do they let me call them by their first name? And this is important to me, because if you're going to mentor someone and be a mentor to them, it's not like, when we come mentor here, it's not about showing these doctors how good you are. It's about showing them how good they can be. And there's a huge difference in that. And the differentiator in there is ego. And you got to be able to, we all have a little bit of it, but you got to be able to check that and make it about the patient and the doctor that's trying to learn, and not about like how good you are. And the third one is, would I invite them to my house tonight for dinner and drinks? Would I see them outside of the professional setting? And and you know what? We've had mentors that have come into our lives and left our lives for various reasons, but like those criteria hold true. So if someone's looking to get in that environment, like, we'd love to help them. If there's a course that we don't offer and someone is like wondering where what it is, like, man, I'd help them find the right course. Like, it's about making the doctor better, not about anything else. The answer is really simple. I wouldn't do anything different. And the answer is this: if I do one thing different, the three of us aren't talking today.
Yep.
Because if you go back in time and you change anything that you would do, you alter the course of the history, and the course of your future, and you would not be where you are today. So you could look back and say, yeah, I would have rather done this, like, would have done that. Like, listen, I had a guy that wanted to pay me an arch in Bitcoin when it was like, $150 a Bitcoin. And I was like, that's the dumbest shit I've ever heard of. Like, I'm not taking that. I don't even understand it. So like, I passed on, right? Like, that could have been $1 million arch. That could have been the most expensive arch in the history of
100%.
yeah, right?
Maybe more than $1 million.
I know, right? So for me, I wouldn't change a thing. I would change a thing, because I love where I'm at.
Good.
God, I hope I wouldn't have gone that bad. Most controversial opinion in so large. How do I get persecuted for this?
Yeah, that's what we like. We get all sorts of answers.
I'm all right. I dislike all informed. And the reasons, I'm going to preface it with, there are humans that is the best treatment for. And if you've been a dentulous for a long time, and I've got unusable sinuses for maybe pathology reasons or whatever, and the only way I can get what the patient desires is to angle some and do a true all on four, old Palomalo standard. I went through that phase actually learning from him. I went through that phase. I people call me, oh, you're just old school Mish style. Like, well, I still like 6 implants, and I like 6 vertical implants. Implants still perform well when loaded down the long axis of the implant. That's science over here, right? But I like 6 for this reason, and it'll make more sense when you've been doing this for 15 or 20 years. And that is the loss of any one implant in an all-on-4 is sometimes catastrophic, but at a minimum, a giant pain in the ass. Wow. If you have 6, you've got posterior support, you've got some stabilization, and the loss of any one implant in a 6 implant system is tolerable. And that is, if I lose either of the posterior terminal implants, I can section the bridge, I could graft the sinus, and I could come back with a single unit or a small little bridge to replace that section. And the full arch in the front is there. If I lose an anterior one, I could just take it out and graft it and do nothing. Because I still might have 5. I can even suffer the loss of 2 and still be where I was if I would have just placed it all on 4. And for me, that controversial thing is on like hundreds of arches of older technology. And I do that. A little disclaimer: I think that the technology and some things that we have to do today are better than when I was doing a lot of arches. But at the same time, true risk mitigation is I still like 6 of them up and down, and they look sexy as hell on that picket fence looks sexy as hell on a post-op pano, and that's my story.
Well, I will tell you that going off of that, our motto at our company, Smile Now, is more than 4. So when we go in for an arch, more than 4 every time. Typically, that for us that means remote anchorage, pterygoids, traditional on 4 on the front, retro framing on the back with the angled. But I agree 100% with everything that you said as far as it's a pain in the ass to lose a single implant in a standard all-on-4 configuration. And that's why we love to tell patients that more than 4, if we can do it for you, you're going to be much happier long term.
Yeah. I know. Hey, listen, I had one little thing on that, and that is, when I was doing, arches and rapid in the clinic, zygos and teres really weren't like an option. There wasn't any place to go do it, and having having Dan Oldsclaw as one of my dear friends, and having taken his course here and learned I think differently about before I met Dan and stuff, I was like, you build the sinuses, you drop them in vertically, and there's still cases that call for that. Because someone asked me the other day, well, why would we even do a sinus anymore? You just do some teres and some things. And I said, imagine this scenario, and I'll challenge you guys for this. Patient comes in, can't afford, just absolutely can't afford, can't qualify for a loan to do the full arch as it is. So imagine a scenario where you can go to Mrs. Jones and say, you know what, let's phase this in so that you can get what you need over amount of time. And so here's what we're going to do today. We're going to get these diseased teeth out of here. We're going to graft the holes, and we're going to put you into an immediate denture for about 4, 5, 6 months, and then that's going to give your pocketbook a chance to kind of recharge from this hit, which was, by the way, was still profitable in practice for what you did. And then you're going to move to phase 2, which is we're going to place the implants. Now, what if we don't have we don't have any bone anywhere? The patient can't afford the exotics, the Zynos and the cherries. Imagine a scenario where, especially in today's economy, where let's just phase 2 is I'm going to do some bone grafting at both of the upper left and the upper right side. And it takes about 10, 12 months for it to like really be good bone. So phase 2 is, it's about $5,000, $6,000, but you got 12, you got 12 months to heal from that financially. And then phase 3 is going to be, we're going to put the implants in, and they need to heal as well. And they've got some time. And so they're going to need 6-8 months of healing. And then the final thing is what you actually want, and that's the teeth that you can smile with and chew with and do those things. And yes, I just talked to you about a 2-year-long program, maybe even a little bit more, but you know what? I can get you what you need to have. It's going to be super sound and is probably as good as we could probably make it. And I've got you from point A to point B, financially. And like sometimes we're so ingrained in like racing to the finish line with full arch that we leave some people behind because it's either full arch or nothing. But what I just told you is more affordable to a lot of people. And guess what? You've got 4 phases of big revenue. And if you hadn't taken that patient out 2 years, you'd have got 0.0 of it.
Yep.
So I think that that goes back to that thing. If you open your mind to hearing what the patient has to say, and like, man, doc, I can't afford that. Well, like, then get super creative at problem solving. Sometimes the problem solving isn't for the work itself, but if the problem solving is for the financial pocketbook, like how do I problem solve for the patient? And that is, let's break this some bitch up over 2 years. Because if you're planning on being in the same location for more than 2 years, like that's a gold mine patient.
Yeah,
it's great. And they got served.
Yeah, I mean, I don't think that that should really be that controversial, and I think that if we're thinking about long game and you've inserted yourself into a community and you want to benefit that community and give back to people, and not everyone's going to be ready for full arch. There's a lot to be said for getting multiple bites of the apple, being conservative, not making everybody fit into the same box. So I can definitely appreciate where that's coming from, and ultimately, being a pillar of your community, giving back, it's extremely important as a dentist.
Listen, I appreciate you guys having me on your podcast. I love following you guys. I love what you said about giving back. Like, listen, you're going to have amazing careers, and you're going to provide for yourself and your families, and that's not a thought. It's a given. And as you move through this, and this podcast goes a long ways, and like as you move through life, like remember, like how you got here was someone, and someone blazing that trail or leading the path. And you guys are approaching the trailblazing, status, and don't take that lightly, like drag some people along the way, because it's where the real gold is. It really is.
Well, I certainly appreciate you saying that. It's very generous of you to say. I mean, with our little podcast here and our audience, we're very humble about what it is that we're doing. But at the same time, I couldn't agree more that, having seen what you did with Implant Pathway and all the people that you've brought along to success with you, it's inspiring to us to do something very similar. This is not about money or status or titles or anything for us. I think at the end of the day, those are things you can't take with you at all. But what you can take is the friends you make and the colleagues you make, and being able to practice without living in a silo. And really, that's why we started this podcast and create this community. And, for us, the person that dragged us along was you. So we really appreciate it.
Yeah. For that, I appreciate you saying that, because for that, like, that makes me, that makes me whole, because that, being able to call you guys friends and be on your podcast and stuff, that's That's better than titles and money and all the other stupid shit. So, yep, yep.
Well, we couldn't agree more on that. And, I think on this show, we talk so much about clinical and techniques and all the pedantic aspects of what we do. But at the end of the day, we're all here and listening to the show because we think about our own careers and our legacies, the impacts that we make with our colleagues and with our patients as well. And there's just so much to say for what you've contributed to the field of implantology, all the people that you've inspired to be doing this. And, you're one of those forefathers, so to speak, that's led to things like this existing. So I think we've asked far too much of your time, and really appreciate you coming on. And hopefully we'll get you back on the show again some other time to talk again about whatever other beautiful way that you've impacted our industry has been. So again, thank you so much for coming on, and we hope the audience enjoyed as much as we did.